This is the first lecture in your mental health course, and it's on concepts of mental health nursing. So what really is mental illness? It's all mental disorders with definable diagnoses. These disorders are manifested in significant dysfunction that may be related to developmental, biological, or psychological disturbances in mental functioning. Cognition may be impaired, like in Alzheimer's disease. Emotions may be affected, like in major depression. Behavioral alterations may be apparent, like in schizophrenia. Behavior that deviates from socially accepted norms does not indicate a mental illness unless there is significant disturbance in mental functioning. So let me give you just a few statistics. Approximately 25% of United States adults have a mental illness. More than 1 out of 20 Americans that are 12 years of age and older reported current depression in 2005 and 2006. And in 2009, the number of deaths from suicide surpassed the number of deaths from motor vehicle crashes in the United States. This is a list of the different mental health disorders that are known in the United States. And I'm not going to go through them. You can just have a look at them on your own time. So we all experience emotional problems, concerns, or occasions when stress and anxiety affects our ability to function. Often these periods of times can be alleviated through life modifications like diet, exercise, rest, talking with friends and family, or early interventions. If not treated early, the patient progresses down the continuum and their ability to respond to stress and anxiety declines. It's important for patients to recognize and seek treatment earlier rather than later. Within mental health, we look at an individual's ability across a continuum, often focusing how an individual responds to stress and anxiety, with such things as their relationships, their knowledge of reality, their work, their self-thought processes, and thinking and problem solving. We also look at their wellness as it relates to others, their effective coping, reality-oriented, how they interact with their real environment, socially acceptable norms, and insight to themselves and others. And then we look at illness, their impaired relationships, ineffective coping, and reality testing is impaired. So the DSM-V organizes diagnoses for psychiatric disorders on a developmental hierarchy. Disorders that are usually seen in infancy, childhood, and adolescence are listed in the first chapter. Neurodevelopmental disorders and disorders that occur later in life, such as neurocognitive disorders, are further down on the list. Within each chapter, specific disorders are listed based on when they typically occur, from youngest to oldest. Diagnostic groups that are related to one another have been closely situated. Examples of this strategic placement include schizophrenia spectrum disorders, and they are next to bipolar related disorders, and feeding and eating disorders are next to elimination disorders. Psychiatric mental health nurses work with people throughout the lifespan: children, adolescents, adults, and the elderly. Psychiatric mental health nurses assist healthy people who are in crisis or who are experiencing life problems, as well as those with long-term mental illnesses. Patients may include people with dual diagnoses, a mental disorder and a coexisting substance disorder, for example. Homeless persons and families, people in jail, individuals who have survived abusive situations, and people in crisis. Psychiatric mental health nurses also work with individuals, couples, families, and groups in every nursing setting. They work with patients in hospitals, in their homes, in halfway houses, shelters, clinics, storefronts, on the street, and virtually everywhere. The admission criteria to a hospital begins with the premise that the person is suffering from a mental illness, and there is evidence of one or more of the following: imminent danger of harming themselves, imminent danger of harming others, or unable to care for basic needs, and or gross impairment of judgment, placing an individual at imminent risk based on inability to protect oneself. If symptoms meet the admission criteria, they are then given the option of being admitted on a voluntary basis, which means that they agree with the need for treatment and hospitalization. If patients do not wish to be hospitalized, but psychiatric mental health professionals feel that admission is necessary, an involuntary admission is completed. Involuntarily admitted patients still have rights and can petition the court for release. If the admission is contested, the treating psychiatrists are required to present the case to the court. The court then decides whether or not to continue with hospitalization. If they're involuntary, they are unable to make important decisions about their care, medications, and treatment. A surrogate person normally makes the decisions for the patient. When they're an inpatient, it could be their physician or a social worker. If you are a threat to yourself or the community, such as saying that I'm going to kill myself, if they're too drunk, if they're dangerous to others, if they're having a psychotic episode, and an example is a boy who was eating furniture and throwing it because he thought someone was telling him to do so. They use the least restrictive alternative. Some may be on a 6-month commitment, but they have to meet certain criteria and conditions. It's not feasible to keep patients in an acute setting for long periods unless it's needed for their safety. The patient may be living at home, but they might have to comply with different conditions on an involuntary basis. An example is seeing the physician, taking medications, keeping themselves groomed, and eating properly. Confidentiality is a large ethical principle with any patient, but especially when dealing with the mental ill, and you really have to remember that. Patients must be informed that their information will stay confidential unless it poses a safety issue, even with the young. Ethics is a study of philosophical beliefs about what is considered right or wrong in a society, and bioethics is ethical concerns that are related to patient care and healthcare. So, holistic mental health nursing. There are a number of things that are involved in this. The first is diagnosis, when you identify the problem and etiology, identify nursing diagnoses and problem list, and prioritize nursing diagnoses. Then outcome identification, when you identify attainable and culturally expected outcomes, document expected outcomes as measurable goals, and include time estimates for expected outcomes. Then there's planning, when you identify safe, pertinent, realistic, individualized, and evidence-based plans. Strive to use interventions that are culturally relevant and compatible with health beliefs and practices, and document that plan. And then implementation. That includes coordination of care, health teaching and health promotion, milieu therapy, when you make the patient feel comfortable and safe, educate, inform, and keep the least restrictive environment safe for the patient, and pharmacological, lab draws, biological, and integrative therapies. And then lastly, evaluation, when you document results of the evaluation. And if outcome has not been achieved or desired level, you have to gather additional data, reassess, and then revise the plan. Your nursing assessment includes a number of things. The purpose of the psychiatric mental health nursing assessment is to establish a rapport with the patient, obtain an understanding of the current problem or chief complaint, review physical status and obtain baseline vital signs, assess for risk factors affecting the safety of the patient or others, perform a mental status exam, assess psychosocial status, identify mutual goals for treatment, and formulate a plan of care. So with your assessments, you want to know the presenting problem. You need to know their past medical history, because many medical conditions can mimic psychiatric illness, so you have to know those. You find out their family history, and you do a mental health status exam. This evaluates an individual's current cognitive process. And then there's a psychosocial assessment. It's the subjective part of the assessment that focuses on the patient's perceptions and recollections of current lifestyle and life in general. And that includes family, friends, education, work experiences, coping styles, and spiritual and cultural beliefs. You also do a cultural, spiritual, religious, social assessment. And there are a number of rating scales to use. Some examples are posted in Blackboard for you, so I'm not going to discuss them here. And then with nursing assessments, you have to think about the age differences. With children, you need to use a variety of sources. Caregivers can help interpret the child's words and responses if needed. Children often tend to regress in behaviors like thumb sucking and bedwetting. You need to use age-appropriate communication, interview and observe their behaviors, and you can use things like dolls, games, draw a picture, have them draw a picture, or storytelling. With adolescents, the main concern is confidentiality. They are very worried about that. So ensure that they understand that records cannot be shared with their parents, that they're definitely private. And exceptions to the confidentiality are threats of suicide, homicide, sexual abuse, or behaviors that place the patient or others at risk or harm. And then with the older adults, you have to accommodate any physical limitations. Make sure you're speaking slowly, and definitely remember that they may have more health concerns. The mental status exam evaluates an individual's current cognitive process, and it goes through a number of different things, such as appearance, behavior, speech, mood and affect, disorders of the form of thought, perceptual disturbances, their cognition, ideas of harming self or others, and their psychosocial assessment. And a mnemonic that you can use to help remember the psychosocial assessment is HEADS, HEADSSS, and that stands for home environment, education and employment, activities like sports, things like that, drugs, alcohol or tobacco, sexuality, suicide risk, and savagery. And this is violence or abuse in the home environment or in their neighborhood. The mental health status exam, you can use the mnemonic BATCAP to help you remember the pertinent parts of it. So behavior, appearance, thoughts, cognition, affect, and perception. The nurse-patient relationship has specific goals and functions, including the following: facilitating communication of distressing thoughts and feelings, assisting patients with problem solving to help facilitate activities of daily living, helping patients examine self-defeating behaviors and test alternatives, and promoting self-care and independence. Protecting the patient is an essential first step when meeting them. Make sure that you check all personal property and clothing, assess for their potential for falls. Visitors can be overwhelming and distressing for patients. They may also provide unsafe items, so make sure you inspect things. Aggression and violence may also result due to living in close quarters with others, and identify developmental risks. You also have to protect yourself, so wear appropriate clothing and keep an awareness of yourself in relationship to others, staff, and where the exits are. So here's a list of important factors that can help facilitate a good relationship, and again, I'll let you go through those on your own. These are factors that can make things worse, so make sure that you go through this list. So one of the most important things is for the nurse to build trust with the patient. This will assist in the therapeutic relationship. These are the phases of the nurse-patient relationship. Study them. It's mostly self-explanatory. However, the most important aspect of the pre-orientation phase is to explore your own self-perceptions of the mental health disease, patient, or situation. These preconceptions may affect the care that you provide to the patient and the relationship that you develop. Let's talk a little bit about communication. Therapeutic touch is used in many aspects of nursing, but you have to be aware that it's not a good way to interact with patients who have mental health illnesses. Factors that affect communication: emotional factors like mood, responses to stress, and personal bias. Social factors like previous experience, cultural differences, and language differences. Cognitive factors like problem-solving ability, knowledge level, and language use. Physical factors like background noise, lack of privacy, and uncomfortable accommodations. Societal determinants like the presence of others, expectations of others, and socio-political, historical, and economic factors. Status of individuals in terms of social standing, power relationship type and age. And it's not a one-way street. You have to watch your nonverbal language and theirs, because it is a lot of what we communicate, especially our body language. Make sure that your tone is appropriate. Watch their tone and watch for eye contact. So, active listening components. Body language is huge. You can use the mnemonic SOLER, S-O-L-E-R. Sitting squarely facing the patient. O is for open posture when interacting with them. L is for leaning forward toward the patient. E is for establishing eye contact. And R is for relaxing. You also have to watch physical characteristics like facial expressions, the way someone holds their head, legs and shoulders. Watch proximity. Intimate distance is 0 to 18 inches, and it's reserved for those that we most trust. Personal distance is 18 to 40 inches. It's for personal communication with friends and colleagues. Social distance is 4 to 12 feet. It applies to strangers or people in public areas. And public distance is 12 feet or more, and it applies to public speaking. You also have to understand in context of life, so listen for the bigger picture. Many times the patient has multiple things going on that contribute to the current disease process or stressful situation. And then you also have to clarify, paraphrasing, restating, reflecting, or exploring. So some interview guidelines and things to remember. Many times people are scared to use open communication with a mentally ill patient, but it's really important. So you want your patient to be talking more than you. Your patient does not want to hear or care about your opinion. Your opinion is not going to help them. We need to understand their feeling to help them. It's what they think that's most important. We are there to listen. So first, meeting a patient. Tell the patient who you are, the purpose of the meeting and how long it will be, and talk about confidentiality, because the patient needs to know that whatever is discussed will stay confidential unless permission is given. When you don't know what to say nothing. Silence can be difficult, but it's also therapeutic. It is okay to respond, I just don't know what to say to that. And then focus on feelings. If depressed, lonely, or sad, what is the message under the communication? Advice will bite you in the end. I did this because of you and now I lost my job, is what somebody could say. So instead, let's think about your options. What are the positives and negatives, and let's write them down. This puts the ball puts it back on them. Don't rely on asking questions. Avoid question after question after question, especially closed-ended questions, because they're not going to be helpful. Makes the patient feel like they're being grilled or on a legal stand. You need to think of more gentle ways to get the information. So giving feedback or paraphrasing, using empathy. It sounds like you're going through a lot right now. I wonder what else was going on when you experienced this. Using nonverbal, or if they are nonverbal, are they focused on other things? Are they fidgeting? What is their body language? Are they scared? Are they using eye contact? Use these cues to help develop questions. I see you're tapping your foot today. Are you nervous about something? Or better yet, can you tell me what you're nervous about? And then focus on the patient. Don't give personal information to the patient about yourself, and always keep the focus on them. Give them empathy, but don't focus on how you handled the situation. And then on the communication level, you should assume the same height, either both sitting or standing. Avoid a face-to-face stance. Slightly angle yourself so that it's less intense for the patient. Be sure to put yourself in a safe spot, and so you're able to get to safety if needed. And then avoid a desk barrier between you and the patient. Help the patient identify and explore problems related to others. Help them explore what's going on, when did it start, and are they doing anything about it. Help them discover healthy ways of meeting emotional needs. What coping mechanisms do they have in place? Are their coping mechanisms helping or hindering the current problem? And then help them experience satisfying interpersonal relationships. Help them identify resources within their family or community that they can draw upon in times of stress. Help them feel understood and comfortable. And this is the most important thing that you can do for them. So tactics to avoid, and this might seem simple, easy, and straightforward, and does not need to be talked about, but it's amazing how much you will see these communication errors occurring. Arguing. Say your patient was telling you that he or she is going to do something that you do not agree with. You need to find a suitable way to talk to them about it and not argue. Patients at times have a way of elevating your response, so you have to keep a close tab on your responses. Minimizing. Oh, that's nothing, or that's not a big deal. Makes people feel small and that you don't care about their problems. An example is a patient that was recently diagnosed with breast cancer. The person responds, oh, that is as common as the common cold. It makes the patient feel as though they did not matter. And then don't give false reassurance. It's telling a patient that everything's going to be okay. You don't know that everything's going to be okay, so don't tell them that. A common NCLEX question is your patient says this. The most therapeutic response to the patient is which of the following statements. If one of them looks like a false reassurance, don't pick it. Probing sensitive areas. If someone says they don't want to talk about that area, you need to respect that decision and don't probe that area. Selling the patient on accepting treatment. Patients have autonomy to make their own decisions if they're in a voluntary status. We need to respect their decisions. Participating in criticism of any staff member. The patient comes up to you and states, that night nurse was really mean. We do not participate in this type of communication, even if you agree with the patient. Instead, we say, we cannot comment on that. Is there something else I can do for you? And joining any attacks led by the patient. If a patient is talking nasty about another patient, we need to intervene and shut it down. No one is to pick on another human being. All right, then a little bit about stress. So stress is the fight or flight sympathetic nervous system. You get an increased blood pressure, increased heart rate, and increased CO2 level. And we use the term GAS, General Adaptation Syndrome. Hans Seil postulated that the body, when exposed to stress, would respond in 3 stages, known as the GAS, that has with these 3 stages: the alarm stage, stage of resistance, and stage of exhaustion. The body responds the same physiologically, regardless of whether the stress is real or only perceived as a threat. And that's important to remember. In the alarm stage, the HPA, or hypothalamic pituitary adrenal axis, creates a surge of energy that causes the hypothalamus to sense stressors. This activates the SNS, or sympathetic nervous system, which activates the adrenal medulla, which secretes catecholamines. Now try and keep up with this. Catecholamines are things like norepinephrine and epinephrine. Norepinephrine increases the heart rate, contractility, and respiratory rate, decreases GI motility and secretions, constricts blood vessels, causing an elevated blood pressure, and dilates pupils. Epinephrine has similar effects, but also increases the release of glucose. The hypothalamus also releases CRH, corticotrophin-releasing hormone, which induces the secretion of ACTH, adrenocorticotropin hormone, from the anterior pituitary, which activates the adrenal cortex, which secretes glucocorticoids and mineralocorticoids. Cortisol is a glucocorticoid. It increases serum glucose by increasing breakdown of protein to amino acids, converted to glucose via glucogenesis. Cortisol also increased glucose, the increased glucose feeds brain and facilitates memory, muscle endurance, and stamina, and suppresses acute phase response to infection and inflammation. And then endorphins are also released within the central nervous system in response to certain stressors, and this reduces sensitivity to pain and injury. So the resistance stage is when the HPA cascade stays activated until the stressor is resolved and then returns to normal. If adaptation does not occur, the HPA axis stays active, which will eventually lead to exhaustion. In the exhaustion stage, the body is unable to return to homeostasis. The stress state becomes chronic, resources are depleted, and disease processes can occur. This is a visual for the general adaptation syndrome during the acute and exhaustion phases. And please try to learn and understand this because it really is the basis for all mental health illness. The cortical changes are to the left, catecholamine changes to the right. Both cause long-term effects, which if left unchecked can lead to many different diseases like heart disease, stroke, cancer, ulcers. And ACTH is adrenocorticotropin hormone, and FFA is free fatty acids. When we are admitting to an acute care setting, like a hospital for mental health patients, they are often under a great deal of stress and often express these attributes that are listed here. Think about what caused you to be stressed 15 years ago. Is it the same as today? Adaptation and coping are influenced by a number of things. Childhood experiences, coping strategies, personal outlook on life and the world. If you're a negative person, then stress may make things worse. Strong social support enhances mental and physical health and acts as a buffer against distress. Self-help groups help decrease stress, and people feel like they belong and are less vulnerable. Positive responses are problem solving with figuring out how to deal with the situation. Social support by calling in others who are caring and may be helpful. Reframing or redefining the situation to see both positive and negative sides, as well as the way to use the situation to one's advantage. And then negative responses are avoidance or choosing not to deal with the situation, letting negative feelings and situations fester and continue to become chronic. Self-blame by faulting oneself, which causes low self-esteem and prevents positive action to solve the problem. And wishful thinking and believing that things will resolve by themselves and that everything will be fine. This is a form of denial. Examining these 4 coping categories can help nurses identify areas to target for improving their patients' responses to stress. Their health-sustaining habits, like medical compliance, proper diet, relaxation, and pacing one's energy. Their life satisfactions, like work and family, hobbies, humor, spiritual solace, arts, and nature. Their social supports, and effective and healthy responses to stress. No single stress management technique is right for everyone. Employing a mixture of techniques brings the best results. You can use relaxation techniques, guided imagery, cognitive reframing, and mindfulness, among a number of other things. So this is the end of part 1 of the concepts in mental health.